Thank you for having me. And maybe just a little bit about my background. I was born in Mexico and I moved to the US when I was 6 years old. And then I went to undergrad, I went to Occidental College. And then I went to Pepperdine University and got my master's and doctorate in psychology. I am a psychologist. And in order to be a psychologist in the United States, a neuropsychologist in the United States, and maybe I think Canada also, you have to do a postdoc after your doctorate. That's the way it works in the United States and Canada. In Mexico, it's a little bit different. So the reason I'm bringing this up is because a little bit later in the presentation, I have a certain proposal of how we could assess people here. Maybe we could interact with students here, or maybe from the United States, they could come down here, maybe we can help assess a lot of individuals down here who are retired and maybe want to find out to get a baseline, and I have some proposals also. As I was mentioned, I worked at Cedars-Sinai. I was there in 2004 till now. I kind of pulled away a little bit, started doing a little more private practice, so I could come down and visit my parents a little bit more often, and maybe eventually even move to Ajijic. Is actually what I'm hoping that I would do that soon. So let me get started. So I have my email here, and I think they're going to make this video available also. So if you want to contact me, this is the very easy email. I use the easiest one I had is Dr. E. Lopez at yahoo.com. And also my phone number is 310-993-8451. I think WhatsApp kind of works well. So if you want to contact me specifically. So what is neuropsychology? So today I'm going to do an introduction, and hopefully I could do more of these and get more detailed. So I just want to kind of at least begin to introduce you to what neuropsychology is. Again, neuropsychology is conducted by a licensed psychologist in the United States, and you have to have 2-year postdoctoral training to do that. And what we do is we study the relationship between brain and behavior. And what we assume is that different brain areas do different things. So what we do is we assess these very specific areas to determine if the brain is functioning correctly. And I'll give you a sample of how we do that with a few measures also. The neuropsychological evaluation, a very comprehensive one, usually is about 6 to 8 hours, so it's pretty extensive. And usually our measures are paper and pencil, sometimes computers, but none of the tests hurt, and we don't plug you up with electrodes or anything. They're just really very simple paper and pencil type of tasks. Some of the tasks are very simple, and some can be very challenging. So what I wanted to start with is first introduce you to a basic functional neuroanatomy, and I'm going to divide the brain in different ways so you can understand it from that perspective. Let's start with the left and the right side of the brain. For most individuals who are right-handed, their dominant hemisphere tends to be left side. Although we use all of the brain, but we tend to use it as dominant because that's where usually our language is. It's always on the opposite side of your dominant hand, usually. So our language will be on this side, and all our like analytical abilities, mathematical abilities, everything that's organized and tends to be there, like numbers and sequences, tends to be on the left side. Then on the right side tends to be more our imagination, daydreaming, spatial awareness, music, and gestalt. So that's really more the right side of the brain. So when I'm speaking right now, that tends to be on the left side. That's what I'm using right now. But if I kind of slow down a little bit and like listen to the birds and kind of daydream a little bit, then this side tends to kind of come on now and stuff also. So it's kind of a way to kind of understand how the brain kind of works, the left side and the right side of the brain. Another way to look at the brain is from the front part of the brain to the back part of the brain. And there's this thing right in the middle that is the motor strip. This is where our body is. The front part tends to be doing things or making decisions. So it's moving and doing something. The back part of the brain tends to be more sensory, is our perception. So back way over here, this is where we have our vision, is actually in the back of the brain. And then we have our auditory area right here. This is our understanding of language, because it's in the back. Then we have our full body here, and the back part on this here is my sensation. So if I touch myself, it's this back part of the body is where my brain is reacting right now. Now, if I move my hand, then it's the front part of the body. The speech area is in the front. That's because I'm actually speaking and I'm doing and I'm moving my lips. That's the motor part. That is, I'm actually doing something. So that's a nice way to understand the brain. The back part is sensation, and the front part is actually doing something. And sometimes when a person comes in and they maybe had a stroke, we could kind of find out where it is by the things that they actually can do and cannot do. What areas are spared and which ones have been injured. Before we had neuroimaging, that's how we would determine where the actual brain injury occurred. Okay, so this is, again, excuse my drawings. So this is actually the body, okay? So this is where our leg goes inside the brain, then our hand is here, and then our face is here, and our tongue is down here. So again, this is the motor area, and this is the sensory area. So if for some reason you can't move your leg or something, then this part of the brain is probably, there's something wrong here, or the hand, or if you have some facial things you can't speak, then there might be a problem down here. So we actually can find out where maybe something kind of occurred. And then again, the front part is when you're moving, and the back part is when you're sensing something. So the whole body is laid out right there in the brain. So another thing to know about the brain is also contralateral. Okay, so on this side of the brain controls this side of the brain. I mean this side of the body, and then this side of the brain controls this side. And it's not 100%. It's about 90%. So if a person, there are people who are not born with one side of the brain, or they have to remove an entire half of the brain because there might be a very large tumor that they need to actually remove it. They still can move their body at about a 10%. So it's not a complete loss. So that's one thing to kind of know, but it is contralateral. And then the other way to look at the brain now is outer to inner. Okay? So the more inner the brain, it tends to be more survival, hunger, thirst, drive, and fear. It's all mainly in the inner part of the brain, way inside. And down here is the brainstem. The brainstem, that's why we injure the brainstem, we can go into a coma. Because that's just basic survival stuff. And then when, like in a car accident, this could be shredded because there might have been a whiplash. And it's not until this heals that a person comes out of a coma, because very internally a person was injured. So that's more internal. And then the more outer, then it starts to be more like intellectual and language and attention and so on. Obviously, the inner part, just evolutionary, that's the area we need to protect because that's just a basic survival. And then the outer parts, they're also very significant, but it's intellectual and stuff like that. So you want to make sure that the survival part, the inner parts, are the most protected. So that the brain is created that way, or that's how it's actually evolved. But it's kind of these are the basic functional neuroanatomy. So with that, sometimes again, like if a person comes to an office and they're able to speak and they talk, but it's a little bit jumbled. It doesn't kind of make sense. or you speak to them and they can't understand you, but they could talk logically, they give them something to read, they could actually read it pretty well. Then you kind of wonder what's going on. So it most likely is the back part of the brain because it's their sensation, or can they hear you, as opposed to speaking. Now the person's speech is slurred is most likely on the front part. And if the person could speak perfectly, but they're bumping into things and so on, that might be on the right side. And they can visually see things like sense that could be in the back part. So that's how we start to kind of figure out where possibly an injury might have occurred by different symptoms in a person. Now what we do is we have a lot of different measures to see what a person can actually do. Some of it, again, like I said, a lot of the tests are paper and pencil, and they could be simple, and some could be very challenging. For example, there's some basic things that sometimes we all kind of need to know, like I should know what my name is, and then relatively know what the date is, and at least by the month or the year. I could be off a few days, so those are kind of basic things we should know. Or repeating a sentence, and I give a sentence to somebody else and repeat it back. That means that they could understand, and can they produce it? That kind of gives me like what areas are actually intact in the brain. Very simply, you could figure that out. Then we have other ones that are really more challenging, and then we could compare people, and we need to compare with others. Like for example, what is normal aging? And then fortunately, but unfortunately also. Okay, fortunately we're living longer, but unfortunately we don't know what it kind of looks like. So we need to get more data, more information, give these measures to people so that we could norm them to see what is normal aging. There is already quite a bit of norms available throughout the world, and that's an area of interest of mine is figuring out what the norms are. And I'll give an example of a test, how we norm it, and why norming is important. For example, we need to know what the person's age is, so we give like a test to thousands of people who are a specific age, and then we compare if you fall like in the same range with these individuals, or if you're way off, or if you're also, it's a strength also, it could also be a strength. We look at education, we look at gender, language is important, nationality. Sometimes, they're mixed stuff, we have age, education, and gender, so we have all these different subsets, which are really nice. And then in terms of research, sometimes we have diagnoses, like for example, this person has traumatic brain injury, this person has. My area of interest, or what my research has been with, is HIV-associated neurocognitive disorders, and that's HIV, because HIV virus can go into the brain, so we assess people to make sure that if they're having, if they're developing dementia or not. So there are studies to find out, well, this starts to look like the person has this type of disorder, because the pattern feels like it's almost identical to this particular diagnosis too. So that's what norm is also, as we compare these measures. So now, what I like to do is to give you a little sample of what a measure looks like. And sometimes how quickly we could figure out something even with a very simple task that only takes a few seconds to give. This is not the actual measure, but I just did a little bit of a sample. It's a little longer. This is developed by Stroop, a very famous individual. I'll have you go through it and on your own, and then once there's three or four sections to this. Once I'm done with it, I'll explain what actually happened. But it gives you a really nice indication of how we actually figure out how the brain is functioning. On this task, what I want you to do, if you could see this, is read these out loud, silently, not out loud, going down in columns, okay? So this is what you're gonna do. You're gonna read it this way. Red, green, blue, red, blue, green, red, green, red, and so on, okay? So just silently, and then just kind of get an idea of how long that took you to do that, okay? So let me just get started now. Just silently, just read it out loud if you could hopefully see it. Okay, ready? Not out loud. Ready, set, go. Okay, I'll stop there, okay? That's the first part. Okay, this is the next part. This one is colors. Okay, hopefully you're not colorblind and you can actually see the colors. But it's the same thing, you know. The only colors are going to be like the one we just did. It's red, green, blue. Okay, so do the same thing. Ready, set, go. Okay. Now let's do a little harder one. And maybe you guys have experienced this, but I'll explain it, how we look at it neuropsychologically. Okay. So on this one, I want you to do what you just did previously, is name the color of the ink. Okay? It's not what it says. Okay? So the first one would be red. Okay? So let's see what this is like. Okay? Ready, set, go. Okay. Obviously, it's a little harder, right? For some individuals, I would think, but that doesn't mean you're brain injured. Okay. This is how it is. I'm going to come back to this one. I want to kind of tease you with language, but I'll explain that. Maybe I'll come back to that one after this. But I want to begin to show you what's actually going on. Okay, with when we give these measures. Okay. So let's start with reading, okay? So I'm going to grab a little marker here just in case. Okay, so your eyes are right here, right? The information goes in here when you're reading to the back part of the brain. It's the sensory part, remember? So you're reading, okay? And then it goes to the understanding area, and then it goes to the speech area. And then, you know, you stop there, but I read it out loud, so then it goes into the lip area, and then I say the word, okay? That's the process of reading. That's exactly the way reading works. We don't have a reading center in our brain. Reading is very new. It's only been about maybe 10, 15,000, 20,000. I can't imagine more than 20,000 years. Reading, there is not a reading center in our brain at all. But it uses all these areas. And it's usually on the language side. For most individuals, it's on the left side. So reading becomes very efficient, and it goes so fast, and it all works very well this way. For people who don't have a reading disorder, this process is very quick. The reading, sometimes people have learning disorders of reading is because we don't have a reading centers. Again, it's a new ability in our brain. Our brain has developed for millions of years, and it's a pretty new thing. And then we overlearn it, so it goes really fast. It goes so fast that if you read a novel, you actually hear a person speaking to you, telling you their story. And that's the way reading should be. So this is the process of reading. So color is a little different. You still see the color. It goes here, but it goes to the opposite side of the brain, to the right side of the brain. I'm just assuming it's the left side, okay? And then it has to come back here, and then it goes to the speech area, and then you're going to say it out loud, the color. So this is a blue marker that takes a little bit of a milliseconds, a little longer than the actual reading when you look at the color blue. Just very slight, okay? So then we have our frontal executive part, the front part of the brain. That's the last part. Our brain likes to be efficient and not use a lot of energy. Okay, just biologically we were born that way. We might have been scarce with food and so on, so the brain works that way. The brain is telling you, do what's easiest, not what's harder, okay? And so it's easier to read the word than to say the color. So your frontal lobes have to kick in, and they say, don't do this one, but do this one. And that takes even a few more seconds, because now the front part of the brain has to come on. This is a very beautiful understanding of what happens when a person has impulsive disorder. With children who have ADHD and so on, what happens, we believe that not enough the brainstem is down here. There's not enough blood that goes all the way up to the front part of the brain. So that's why you need a stimulant, because it actually shoots more oxygen, blood levels to the front part of the brain, and it actually calms the person down who has a frontal lobe problem like ADHD, and then now they could actually sit down and listen. It takes more energy for you all to be sitting down listening to me than jumping around and dancing and so on. It requires a lot of energy for the brain to inhibit and to sit down calmly listening to me. So that's a really nice understanding of how we look at these measures to help us to understand how this is how people are doing. Okay. Now, how do we know that what you did, do I have a brain injury or do I have a frontal lobe problem or so on, that one last measure? We do it through like the best easiest way that I describe it is a marathon analogy, okay? So in a marathon, you usually have your first place person, right? Then second place, this is the finish line, okay? Second place, third place, and then we have a lot of people behind on a marathon, and then we have a bunch of people in the middle, and then we starting to imagine there's 99 people running the marathon, okay? And then you start getting your slower individuals, and then you have your slowest one, second to the last, third to the last, and so on. Okay, so that's kind of how we measure, how most actually science and medicine does this. So we gave this test and we take seconds, how long it took you to do that last test, the one that's a little more comprehensive, and we find out where you fit in with individuals. We've given this to thousands of people, so we'll know where you actually fit in. So we consider, imagine there's 99 individuals, and this is first place, but I'm going to reverse it. I'm going to call this number 99. And this is first and second. We consider 25 to 75 to be in the average. If you run a marathon and you're here, you're okay. You're just with everybody else, okay? We have our fast people sometimes, right? We have the winner, right? The first place. We call this the very superior. And then we have 98 is the superior, and then we have the high average individuals. That's, usually first place, they give them a trophy. They're just way beyond most individuals. The same thing goes to us in that we tend to focus in clinical work on this area, not this area, although we have people that are here all the time, okay? Some people think like, oh, I have ADHD because I'm here, but they want to be over here. That's not ADHD. That's where we have to really do an assessment to find out really where they fall in with everybody else in the norm group. So we start diagnosing individuals there's mild and then there's major, okay? Major is pretty much the last person, and then the mild tends to be more like from the second to the ninth. This is where we start getting maybe concerned and want to make sure we're kind of aware that something might be going on. But this is when we start diagnosing individuals, okay? Let me explain what mild and major is. The book that we use for diagnosing individuals in psychology and psychiatry and neurology is the DSM-5. And the DSM-5 now requires that you do documented neuropsychological evaluation to help determine where a person fits in the mild or major. We've used in the past dementia, but the DSM-5 has removed the label as dementia now. They call it mild neurocognitive disorder or major neurocognitive disorder. And you have to have one domain or more domains impaired in a specific area. So again, this is how we begin to kind of classify individuals. Hopefully that makes more sense how actually we really do evaluate individuals and how we determine if a person has a problem. Because sometimes it could just be normal aging also. Maybe you were in the superior and now you saw a little bit of a drop, but that might just be normal aging. But you do notice the difference. Sometimes I notice that people who are very bright actually notice the difference. but it might be a slight drop too. So again, it's how do we, making sure we assess people accurately is what I'm hoping that we could kind of do. So now I was going to go through the different domains that we assess. Just kind of looking at how much time I have. So the domains that we assess, so I just gave you an example of an impulsive task. And again, remember, these measures, we test people for about 6 to 8 hours. Sometimes we do abbreviated when we do research studies, or we would do like a wellness. Then sometimes we do more like 2 or 3 hour evaluation. And then if somebody really needs it, then we do more extensive. So the domain we assess is intellectual. That's also helpful. Just to know what's the capacity of the individual. Intellectual, unfortunately, we don't assess like music and creativity and art. I think, in the medical center, we're more kind of precise. Okay, can this person speak or can they see and so on. So we're more kind of looking at these major problems. So, I love consciousness and so on. But then we don't kind of do that. It's fun and exciting, but when we actually are trying to diagnose individuals, we're looking at these very specific areas. Intellectual abilities are usually divided into verbal and visual. Some people have strengths and weaknesses. I tend to be more of a visual person. Some people may be more verbal, like writers and so on, attorneys and so on, and visual people are more mathematics and sciences. Intellectual also is working memory. Working memory is, and I'll kind of go through it a little bit more here. I'll explain that in a second. And then also how quickly you could think also. That's also can be important in intellectual functioning. This can start decreasing. I worked with Paul Satz, was the advisor director when I was at UCLA, and he's a world-renowned neuropsychologist, and he's no longer with us. And he always talked about that as we age also, we don't need to be running around and people say, I can't think as fast as I used to. It's also normal that is occurring because he thought that actually wisdom is also important. And you don't need to be running around, you have to be doing everything the way you used to, and memory has to be perfect. He thinks wisdom is also important. That's something I want you to be aware of, that wisdom is also, as we age, becomes more important than how fast you do something, too. So I just want you to be, it was very lovely how he would describe that. He thinks that, it does happen when we're born, we lose half of our neurons by the age of about 4 years old. And if you don't lose them, you could have an intellectual deficit. You actually have to prune your brain so it works better. I think the same thing also happens when you get older. There has to be some pruning so that wisdom comes about also. So it's also normal that is occurring. So that's one area we assess. Then we have attention, working memory. Working memory is like what you're actually doing at the present, in the moment, like what I'm doing right now. There's 2 things that we label, like for example, there's this process in working memory called the verbal loop. If I give you a phone number, and you don't have anything to write with, you might repeat it in your mind several times till you get to somewhere where you could write it. That's called the verbal loop. Like 9938451, 9938451, 9938451. They say that our verbal loop for most human beings is 7. So that's why the phone numbers are about 7 digits long. In Mexico, they're a little longer. So they're a little harder. I have a really hard time with Mexican, numbers in Mexico, but in the US, they're a little easier because that's why they're 7 digits. You just know the area code, and then you do the 7 numbers. Then we have another thing called the visual chalkboard. Visual chalkboard is where if I give you, what is 15 times, 13 times 5? That's not in our timetable, usually. So then you sometimes people, what they do is in their head, they see the 13 and then the 5 and they kind of create it in their head. That's called the visual chalkboard. So you're working, it's kind of like RAM, maybe you want to use a computer. It's like what you're actually kind of working with. Visual scanning, everything I'm scanning, everybody, do I need people paying attention or not? Divided attention. Human beings tend to be able to do this because we have a large frontal lobe. Divided attention is when can you do 2 things at the same time? Can you switch back and forth? There's a test where you do, for example, you do 1 A, 2, B, 3, C, and we have them go pretty far. Can they do that, and can they use that divided attention? Then we have sustained attention. Can you stay on a task for a long time? We have this very boring task. Computer says all you have to do is just press the space bar every time you see a letter, except the X. There's 360 letters. Like if it's 15 minutes long, for a little kid who has ADHD, they're like, oh my God, I'm excited as a computer. They're like in it for about 5 minutes, and after they're like, oh, I think I see a little ant. You know what I mean? They lose track of what they're supposed to do. That's sustained attention. And then hyperactivity also. We have a test where we use for children who have hyperactivity. It's a statue. We have them hold their hand and do a little statue, like a Statue of Liberty. They close their eyes, and it's only like maybe 3 minutes. And if they could stay that long, a child who's hyperactive cannot, stay for 3 minutes with like a pretend they're a statue. The first 15 seconds are okay, and then you do these little things to see if they get distracted. Like you do this, and then they open their eyes and they're no longer the statue, and so on. So these are measures that we use. We have language, receptive and expressive. Receptive is can I understand, and expressive, can I say something? Repeating a sentence is actually a very difficult task. If you can understand and repeat the exact same sentence, that means the language side, most of it is working pretty well. It's very simple, but that's the language area, receptive and expressive. Verbal fluency, how quickly. We use this a lot for neuropsych measures. For example, how many animals can you say in 1 minute? And there's a norm. Usually if you could say at least 11, that's pretty good. But again, this is all normed also. But if you want to do a little self-assessment, how many animals can you come up with 1 minute? Is a good one. Visual, can you copy designs? We have these really complicated designs. We don't do it for artistic purposes, but if they could see the major pictures, the little details, so we copy things visual spatially. And then also, if you could identify things, like we have pictures of stuff, and do you know what this is? Can they make it out? Like a picture of a table or a chair and so on. Then memory. Memory is mainly the one I'm interested in. Episodic is events, is remembering events. Semantic is knowledge, facts, and procedural would be like motor skills. Okay? Like if you learn to ride a bicycle, it's a very different part of the brain. Sometimes people might have memory problems with very specific facts and events. Like an event would be, for example, when I was a child, I would come to Guadalajara to go to my uncle's library. That would be an event that I remember. A fact would be Guadalajara is the second largest city in Mexico. That's a fact. That's a fact. Okay. And then motor skills would be like a bicycle. It's a different part. It's kind of unconscious. Sometimes you learn things, and you could always learn. Sometimes people who have memory problems, episodic or semantic, they actually can do new tasks and do motor abilities. And these are the different parts of the brain that deal with these specific areas of the memory. And then the motor, we have a non-dominant side and a dominant side. And it's usually about a 90% difference. So we have people do something with their, like for example, can you sign with your right hand and then sign with your left hand? And we time it, and then we see what kind of a difference there is. So motor is to make sure, this is unusually slow. Why would your dominant hand be so much slower than your non-dominant? There might have been a slight little stroke or something. So that's how we assess that area. And then the front part of the brain, like the measure that I showed to you, inhibiting or and then the other areas we assess is academics, reading, writing, and math, how a person used to do before, to give us an idea of how they were before an injury kind of happened. Because usually academics don't change. Academics kind of remain like that for the rest of their lives, even with an injury. And then I also like to assess emotional stuff, because then emotions people who are depressed, there's this term called pseudodementia. It actually might be depression also. Anxiety also can impact. Inattentiveness, or you're distracted, you're too anxious. And so that's kind of basically with neuropsychology and how we assess. And then what I was kind of hoping is to propose, let me see, maybe I'll just go through this. I might only have a few more minutes left, but what I'm going to, when is an NP evaluation indicated, neuropsychological evaluation indicated? It's just your knowledge or get a baseline, just to know how a person is. When a person, to help diagnose a person for capacity or disability. Also, it's appropriate for therapy, like we could guide the therapy, oh, and the person needs this, and so on, or to inform their significant others also. And what I was hoping, and again, that's why I said this is more of an introduction, because of COVID, things got kind of moved around for us in the last year and so on. I was going to go to Thailand and create a brain wellness center for people who live in Singapore and Hong Kong. And they asked me if I could go there for about 3 months and see if I could organize that. But then that got moved around. So I was thinking that maybe we could begin something here in the Lake Chapala Society. And again, it's just beginning to have that conversation so we could begin to assess individuals. What I was hoping is getting connections with the university here, people who, students maybe who actually come from the US. We live in Los Angeles, a very quick flight. People can help assess and create some kind of a program here. Screeners, brain health education, and then also a support system here. But also maybe the students from here, like La Universidad Autónoma of Guadalajara, there's some English-speaking individuals that maybe can help us with the assessments. But then we could also have something at the university there, so we could assess people who are Spanish-speaking also. That's basically what I wanted to kind of to begin to kind of present to you, and hopefully, continue to do these talks and more focus on then brain health education and so on, just the initial talk. Okay.